afternoon, everyone. Welcome for the webinar series conducted by the Staff Development Committee, Faculty of Medical Sciences, University of Sri Jawatanapura. So today we will be talking about all our questions answered on COVID-19. So in order to conduct the session, I would like to invite Dr. Saraji Veerasekara to introduce our panelists. Over to you, madam.
Good afternoon, all of you. As Sajid mentioned, we are at the panel discussion on all your questions answered on COVID-19, and we have invited 4 eminent speakers today who have been battling with COVID since the inception, that is March 2020. So let me start with the first speaker. He is Dr. Harsha Satish Chandra. He's a consultant physician in internal medicine attached to National Hospital of Sri Lanka. And also he's the current president of the Sri Lanka College of Internal Medicine. Secondly, we have Dr. Shana De Silva, consultant pediatric pulmonologist attached to Lady Ridgeway Hospital for Children. And he is the current secretary of Sri Lanka College of Pediatricians. And third and fourth speakers are our very own speakers, you very well know from our faculty. Prof. Neelika Malavige, Professor and Head Department of Immunology and Molecular Medicine, Faculty of Medical Sciences, University of Sri Jawatanapura. And we have Dr. Madhura Jayawardena, Senior Lecturer and Head of Department of Obstetrics and Gynecology, Faculty of Medical Sciences, University of Sri Jawatanapura. So with these 4, over the next 1 hour or so, we are trying to discuss some of the aspects that have maybe not been answered to date. So all of us know that since March 2020, since the first patient was identified in Sri Lanka, we have been having more or less many patients, and I think this was the worst hit that we had over the last few months, where the country was closed to upon 4 to 5 weeks. And we have had patients flooding into the hospitals, and the hospitals were overflowing. Therefore, we had to take several measures. The government had to take several measures to manage them effectively, because we were managing the asymptomatic patients also at one point in the hospitals and the intermediate care centers, making the lives more difficult. So I think the first speaker, Dr. Satish Chandra, so I would like to ask you now, since of late, we have been starting managing the mild COVID patients at home. And if you could just elaborate, just to revise, just to give us some idea about the symptoms of COVID-19, and also the symptoms, the mild patients who are managed at home, what sort of symptoms do they have to be on the watch out, sort of being monitored?
Yeah, thank you, Saraji. I must thank the organizer for inviting me for this talk. Yeah, I think it's a very important question. Now we know that lots of patients are under the home care management system. And I think the system has worked fairly well over the last couple of months or so. Now, if we go back to the symptomatology of COVID-19, what we say is that the incubation period, especially with this Delta variant, is about 4 to 5 days. Initially, we said it was 5 to 7 days. Now it's even shorter. And then they become infectious about 2 days before the onset of symptoms. And then the viral load progressively increases over the first few days, and then it declines. Then symptom-wise, initially what they get is the normal respiratory symptoms. The symptoms, sore throat, and body aches, headache. But there are 3 symptoms that are of particular concern to all of us, and they are fever, and then there is a dry cough or worsening cough, and shortness of breath. I think those are the 3 symptoms that we have to be really careful of. Of course, one could have loss of smell and taste. So those are there in these patients, but the ones that we should concern about are the symptoms that I mentioned. Now, usually what happens is once they initially the first symptom might come on, and then over the next few days they may have fever. Initial fever in the initial couple of days is not a major concern as long as it's not very high and it settles. Usually it settles within the first couple of days or say by about day 3. But we should be careful if the fever goes on beyond 3-4 days, and especially if it goes on close to 5 to 7 days, and that may be a warning that the patient is not clearing the virus. So that's when we should be very careful of patients who are in the home care system. And then, of course, cough could worsen. I mean, it's typically a dry cough, but if a patient with asthma who already has asthma gets COVID, they may have an exacerbation of their symptoms. They could have some sputum production, but it's not invariably there. Then the main symptom that we are worried about is shortness of breath. I think that's something that we have to teach our patients about, and we should make them mindful of that. And I think with earlier variants, what we noticed was that shortness of breath, of course, indicates lung disease. So what we noted was that that sort of happened around day 7 or close to day 7, well after day 5 at least. But with the Delta variant, perhaps because of the high infecting viral dose, the patients do present with these warning symptoms, with these sinister symptoms a bit earlier. So I think you have to be on the lookout for these symptoms from about day 4 onwards, like. And if they describe shortness of breath, that's something that we have to be really careful of. Now, shortness of breath can be either at rest or on exertion. So I think the instruction we should give patients is to observe themselves when they are resting, either sitting or sleeping, and see whether they are comfortable. I mean, and also we could teach them how to count the respiratory rate. I mean, we could ask them to place their hand on the chest wall and then time the chest movements and see how many movements are there per minute. And this is important because in this entity called silent hypoxia, even if the patient is not sort of quite breathless for somebody to see, I mean, if you check the respiratory rate, that has to be high. Physiologically, that has to be high. So it's something that we can teach them. And then what we can ask them is if they are comfortable at rest, and it is only if they are comfortable at rest that we should ask them to do this, to do a bit of mild exertion and see how they feel. I think one common thing that we ask them to do is to sit and stand using a chair for about a minute, and we could get them to do it about 6 to 8 times, and let them tell us whether they feel short of breath or not at the end of it. And also, it's important to warn them if they feel short of breath, say within once they start doing the maneuver 1 or 2 times, they should stop doing that and inform the call center urgently. And then, so at the end of 1 minute, they could just observe themselves to see if they're panting. So if that happens, if the respiratory rate goes up, then of course we say that the patient is hypoxic on exertion. Alternatively, we can get them to take about 40 steps, close to 40 steps, get them to walk inside the house, and then let them see whether they feel short of breath or not. And even you could even use the daily chores to assess a patient. You know, if a patient goes to the toilet and then washes himself or herself and then feels very short of breath after that, then that again is a sign of hypoxia on exertion. So hypoxia, either at rest or on exertion, is a clear warning symptom. And I think it's very important that those patients are taken out of home care and into hospitals. And Another thing that I would like to stress on is, so as I mentioned earlier, so if the fever is not settling, the fever is increasing, then of course that's another warning symptom, particularly towards the latter part of the first week. Now, some patients do have pulse oximeters at home, so we could, if they do have those, then we could instruct them how to use them. And then, so we say saturation should be at rest or on exertion should be more than 96 for it to be normal. So 96 is a safe cutoff point because all our treatment protocols start at the saturation level of 94. So I think it's better to leave a bit of a margin and instruct them to inform the call center if it is less than 96. And another thing that I would like to mention is that, I mean, there are patients who may not sort of, who do not fall into these categories. That's either having hypoxia or possible hypoxia, having high fever, or having a very bad cough. Still, if they feel very unwell, I mean, that we have noted that, some patients, I think it's true of many conditions, but if they feel unusually sick, then that's also an indication to get them into hospital for an assessment, because it's, we know that during this pandemic, if you take Sri Lankan data, if you analyze the deaths, close to 25% of the deaths have been either deaths at home or deaths on admission to hospital, or deaths within the first 24 hours. So clearly they had presented very late for some reason or the other. It may be by patient choice, but my colleagues in the JM office at the National Hospital, they tell me that when they do the verbal autopsy, the patients seem to, and the relatives had said that the patients had not been too unwell, but then over a day or two, the patient had deteriorated a lot, and there was not much time for them to get the patient to hospital. So possibly, it's possible that they are not sort of, being mindful of the warning symptoms. And so I think we have to be a little proactive and get them out. And also we must be careful about now, say when calls do come to either 247 or the call center, we have to be careful about a few things. Now, I mean, the home care system is designed for people under the age of 65, and we do not keep elderly patients at home. And also, it's not designed for people with comorbidities. Now, that has to be assessed very carefully, and we do need to ask them specifically for comorbidities. And if they do have those, I think it's important that we either pay extra attention, or I think it's probably better for them to be in a hospital. And also, it may be important to ask their vaccination status as well. Some patients who are unvaccinated are at high risk of developing severe disease with COVID. So it's important to ask them whether they had taken the second dose 2 weeks before, or whether they are not vaccinated at all. So that vaccination status is also important. And in an unvaccinated person who's at home, I think we should monitor the symptoms very carefully. So I hope, Saraji, I answered your question. I think that's the broad thing that I could think of.
Yeah, right. Thank you. And what sort of general measures that should a COVID patient adapt to? And also, how should they isolate? We know that only one person in a household may get affected and they are sent for home care. So how can we minimize the others being infected?
Yes, that's a good question. I think the main basic thing is, if there is a facility for the person to have a separate room, that's best. And I think that will sort of prevent transmission. And of course, wearing a mask when the person comes out of the room, there'll be source control there. So that's an important thing. It may not be practical for other people inside the house to wear a mask at all times. I think that's a little difficult. But of course, to a degree, I mean, if they do come, say at the time of eating, so maybe they could separate themselves, get the person with the illness to eat first, and then the others can do so later. So to minimize contact, I don't think there'll be any way of preventing transmission 100%. And then one other important thing is that by the time one person turns positive, we know that the person would have been infectious about 2 to 3 days prior to the symptom onset. So probably the others had been exposed to the virus as well. So it's a very common occurrence during this Delta wave that we see the whole household being infected. So that possibility is there, but still it would be rational for the person with the illness to isolate as much as possible, maybe inside the house, in a separate room, use a separate toilet, wear a mask when the person comes out of the room, the others to sort of minimize contact, and do whatever practical. And then, of course, the others, I mean, at the earliest sign of symptoms, it might be a good idea for the others to get tested as well, because we say that, I mean, it's very likely that there is spread inside the household. So we have to accept the degree of spread inside the household. I mean, it's inevitable, but we may be able to minimize the risk. So by adopting general measures.
Thank you, Dr. Harsha. Yeah, sorry.
Yeah, now we'll move on to the pediatric age group. So my question direct to Dr. Chana De Silva. So, sir, now we are aware that a lot of children are getting affected by this COVID-19 pandemic. So could you elaborate on what is the status of this COVID-19 on children and the severity of this disease?
Yeah, thank you, Sajid. Actually, one thing is that fortunately, although the numbers are a little high because of this recent outbreaks with third wave, but roughly when we consider overall picture, the percentage of children who develop the disease is less in comparison to the adult. There are a lot of courses. There are some of these courses are maybe theoretical, but the thing is, overall, basically, they are the disease severity is less, and as well as the risk of developing disease is high. One thing is maybe due to some sort of their internal arrangement, especially the ACU2 receptors, which receptor which the virus binds. There are some changes in comparison to the adults, as well as their immunologic mechanisms. As we know, it's mainly the immunological mechanisms which plays a major role in adult patients who develop the severe disease and death, especially the COVID pneumonia and rest of the major issues. And then children, other thing is they are usually the coronavirus is one of the main viruses. They usually develop this upper respiratory tract infections. So there might be some cross reactions of this already existing antibodies. And other thing is obviously some social reasons. The children usually they are less exposed to the outside environment in comparison to adult. And in comparison to the adults, children, they don't have underlying diseases like chronic diseases, which we usually see in adults. So these are the usual reasons why these children, even though they develop the disease, the severity is little less. So most of the time, over 80% of the time, it's a mild disease. Usually they develop mild upper respiratory tract infections, usual viral upper respiratory tract infection involvement, or the features suggest of viral upper respiratory tract infections. They might have mild fever, headache, some sore throat, and some sort of body ache. And some children, it's around 10% of them, have some gastrointestinal disturbances, vomiting and diarrhea. And older children might show features of like in adults anosmia like symptoms. The severe symptoms, usually the percentage develop this severe COVID, especially COVID pneumonia and multi-organ involvement, it's obviously less than 2%. In this, if we consider the current situation in Sri Lanka, still we don't have the official data, but roughly according to unofficial data, around over 50,000 children, especially less than 18 years, has affected up to now. Roughly it's around 53,000, and out of these 53,000, about 65 children less than 18 have died already. But there are various causes. It's not the only the COVID is not the only reasons, but it's in some of these cases. But this death review going on. Other important thing is the MIS-C. So this is the emerging threat in children. This has been identified in the world just about a year ago. Last year, 2020, around April, the Western countries, they have noticed that there is some increase in the Kawasaki disease. But later they have identified this is not the usual Kawasaki disease, but there's something different with the routine thing, and there are some overlap with the toxic shock syndrome features. And finally, they have identified there is some association with the COVID infection. So that is then termed as MIS-C in USA, multisystem inflammatory syndrome in children. And UK, it is PMIS-TS, pediatric multisystem inflammatory syndrome, temporarily associated with COVID-19 infection. So finally, WHO adopted this MIS-C term. And Sri Lanka also, now we are seeing patients. According to the world calculation, it's about 1 in 5,000 children develop this disease, but we don't know exact figures in our setup, but seems to be little more in our setup, or most probably we are missing the some cases. That might be the reason our percentage little high. So these are the basics things that Sri Lanka going on. Other thing is, even though we didn't expect the silent hypoxia in children, it is also been reported in Sri Lanka as well. I am sure most of you are aware that one girl, 12-year-old girl, presented to hospital. That time she didn't have significant dyspnea or breathing issue, but at the time of hospitalizations, when she came to LRH OPD, saturation was 60%, and she was arrested at that time, so have to intubate, but finally she has succumbed due to this illness. So that type, as Satish mentioned, adult patients, it's common, but pediatrics, especially teens also, that is there. Another thing is, most of the children who have died had some issues, especially long-term chronic diseases, as well as especially in infant. We have noticed that the reason for death is one of the most important thing is delayed presentations. Few infants already died at admission or already had very critical disease at the time of admission. So it's important thing is, as if I summarize the Sri Lankan situation and the situation in children, it's usually, fortunately, mild disease. It's most of the time they develop just show features of upper respiratory involvement with mild disease, which usually settle within first week of infections, and usually we can manage with symptomatic management. Small percentage, around 2%, develop the severe disease. Out of those also, about our Sri Lankan mortality rate, these are not official figures, but roughly according to the cases that they reported to us, it's about 0.1%. And other thing is this MIS-C is appearing. We have many cases of MIS-C throughout Sri Lanka. Also, we have noticed that cases of MIS-C are coming on. The most important thing, sometimes now it is as we know, but initial phase, some of these children have managed as maybe leptospirosis, even appendicitis, some because this overlapping presentations. We can discuss about MIS-C a little later. So it's very important to have some sort of suspicion about the children possible MIS-C, but otherwise it's mainly a mild disease. And now we have started the immunization for children also with this type of comorbidities, because that's a vulnerable group who develop morbidity and especially mortality in children.
Thank you, sir. Thank you for that explanation. Before moving on to the next speaker, I would like to mention a small housekeeping messages. So please keep your microphones muted, so it will not disturb the ongoing discussion. At the same time, if you want any help for the COVID, please feel free to dial 247, which is the Sri Lanka Medical Association free health service number, or the patients can SMS to 1904, which is operated by the National Operations Center for COVID Prevention Outbreaks. So I would like to invite Dr. Saraji to introduce the next speaker and move ahead with the discussion.
Okay, thank you, sir. So we'll move on to the obstetrician now. Madhura, so we know that many females panic when they get pregnant during this COVID pandemic. I mean, the maternal mortality and morbidity has been sort of in the news. They say that there have been some maternal deaths during this pandemic due to pregnancy. So, so is it okay to get pregnant during this pandemic? What is your idea? And especially in this wave where the Delta variant is the predominant variant that we have found in most of the patients who have been infected.
Thank you, Saraji, for asking that question. It's a very frequently asked question these days. But before answering that, we need to keep some facts on the table, because it's going to be an informed decision at the end whether someone is going to get pregnant or not, and it's a individual decision, and because this is a democratic country. So if you look at it, when someone is pregnant, is she more likely to get the disease? If you compare a pregnant woman with a non-pregnant woman, she is not at increased risk of getting the disease. Initially, in the first wave and the second one, we thought, okay, pregnancy is not, pregnant women are not at increased risk of getting the severe disease. And in fact, we did not see much of severe cases. But however, because of this new Delta variant, we start seeing a lot of patients getting the disease, obviously because of the Delta variant being more infectious and more severe. And then we start seeing patients ending up in needing like oxygen, intubation, ICU care. And there are reported increased number of maternal deaths. If you look at Sri Lankan data, I think we have lost already like 51 or 52 moms because of COVID. So it obviously appears that if you get COVID, there is a risk of getting severe disease and end up even in possible maternal death. But having said that, still, even with the Delta variant, most of pregnant women are actually asymptomatic. I would say, like from the large cohort that they are following, like still about 80% of the time they are asymptomatic. And out of those symptomatic women, majority are again with mild disease, and roughly about 5% will end up in severe or critical disease. And those are the people who will possibly end up in getting ventilated, ICU admission, and then end up in maternal death. So it's always, you need to look at, when you look at the moms who have died, and majority are non-vaccinated, like 98% of the time it's non-vaccinated. And there are obvious risk factors that you see, like high BMI, more than 30, age more than 35, and those women who are having comorbidities like hypertension and diabetes. Those are the people who are at increased risk of getting a complication even with the pregnancy. So, and when it comes to the fetus itself, like fetus at increased risk of fetal growth restriction, there is a risk of preterm delivery. But apart from that, congenital malformation, those are not reported during COVID. So if you put all this available evidence into the context, I think individual person can decide whether she wants to get pregnant or not. As a general rule, like to prevent maternal deaths, someone can ask, okay, don't get pregnant, so you prevent a maternal death. But pregnancy is a very sensitive thing to people. Like people take too much risk. Like we've seen patients who are having cyanotic heart disease, absolutely contraindicated for pregnancy, still getting pregnant and go through pregnancy because that's their wish and belief. Okay, so I think like if you are, we can't generalize terms like this time is not good for pregnancy also, but we can encourage people to get the vaccine. We can see whether they are at increased risk of the disease, and then we need to inform them and allow them to take that decision. And those people who are suffering fertility for a long time, if they delay another 1 year or so, then that may not be good for their fertility as well. So it's all depend on the individual person, I think. And we have enough information and evidence for them, for those women to like be aware of and get an informed decision. So I don't think we need to generalize. Of course, if someone like not planning to get pregnant, this is the right time to go for a proper contraception and delay, because this is a risk period. But those women who just like need to get pregnant, I don't think there is a real reason for delay, but they need to consider trying to get the vaccine first and then try for a pregnancy. I think that answered your question, Saraj.
Yes, thank you, Madhura. I think when you mentioned vaccination, my next question to you is on vaccination. So now, in vaccinating these ladies or pregnant women, is it pre-pregnancy, post-pregnancy, or in which trimester? And do you recommend any vaccine for them, like any specific vaccine? We know that we have several vaccines in Sri Lanka. Is there any specific vaccine that you recommend, or like any trimester that you recommend?
Okay, so there are a few questions that we need to answer. Yeah. So first thing is whether it is pre-pregnancy or during pregnancy. For any vaccine, I think it's better if you're pre-pregnant. And the question here is, sometimes those women who are trying to get pregnant, they are worried of getting the vaccine because there is a misnomer saying that this vaccine might affect their fertility. I think there is no evidence whatsoever, even physiologically, theoretically, any one of those vaccines that we discuss will affect their fertility. So if someone is not pregnant, you can get vaccinated beforehand. And in fact, even WHO recommend you don't even need to do a pregnancy test to get the vaccine, because the other question is, pregnancy a contraindication for vaccination? Not at all. So far, the evidence of, I think we have four vaccines like Pfizer, Moderna, and then AstraZeneca and Sinopharm that we commonly use in Sri Lanka. None of these vaccines theoretically is going to affect a pregnancy. And we have used most of the vaccines before, during pregnancy, and none has shown any congenital malformations or something like that. So you can take it considering the risk that we discussed before, because pregnancy is a risk factor. So if the vaccination is going to prevent you getting a severe disease, obviously that you can take it. Then the other question is which trimester that you need to take it. I think any trimester you can get it, and it is recommended to take at any trimester. If someone has taken it before pregnancy, even in the first trimester, you can take the second dose. And even in third trimester, first trimester, second trimester, you can take it at any time. But however, like considering the outcome of the disease, because we are giving it to prevent or reduce the severity. So more severe disease comes in the third trimester. Therefore, if you can get it before the third trimester, and if you can complete the 2 doses recommended, so that you have enough immunity to support you during your highest risk period. So I think it's sooner the better. And any trimester, if you fail to get it before, then still you can get it. Even after pregnancy, during breastfeeding also, you can take the vaccine. I think so far, vaccine has not shown any adverse events on pregnancy. Any, like you name any vaccine, it has not. But however, if you ask which vaccine is better, I think the best vaccine is the vaccine that is available to you, because the vaccines are not available. I think you can't purchase. Most countries will provide you the vaccine, and the available vaccine you need to take. And Sinopharm is the commonest one that is available. I think you can take it during pregnancy because there are no adverse events up to now. Of course, there are like local reactions, the mild systemic discomfort, mild fever, all that. But those are not going to affect the pregnancy adversely, but the benefits are much more than the side effects and potential problems. Like AstraZeneca vaccine, if you take it, like there is a slight increased risk of vaccine-induced thrombosis and thrombocytopenia, and that is also very rare. I think it's less than 1 in 100,000 vaccines. So even that is negligible, and you can still take it during pregnancy. So whatever the vaccine available, you can take it. If you want to summarize, I think it's early the better, because you need to protect yourself in the 3rd trimester where you are at highest risk, but you can take it at any trimester. If you're not pregnant, you can take it even in the, better to take it before getting pregnant. And it's not going to affect the fertility of a woman.
Thank you very much, Madhura. So I think that explains all the questions on vaccination and the pregnancy-related outcomes. Sajid, you want to carry on from there?
Yeah, thank you, madam. My next question goes to Professor Nelika Malavike. Madam, now all of us know this pandemic has affected us very badly, but obviously we can't keep everything closed forever. Obviously, we need to move forward with a new normal life. So how would you recommend to move forward? Because obviously we can't eradicate this virus in another 1 or 2 months' time. So how would you recommend to move forward, madam?
Yes, I think the important thing to understand is that we can never eradicate this virus, not in 1 or 2 months, but for as long as we live. But eradicating the virus and eradicating getting rid of the pandemic are 2 different things. So, I mean, we have examples in previous pandemics, like the Black Death, the organism that causes Black Death is still around, but we don't get pandemics with Black Death anymore. The virus, influenza virus that killed 50 million or more people in 1918, 1919 is still around in different changed forms, but it is not causing pandemics, but it did cause a pandemic due to H1N1 in 2009. Okay, so it did cause a pandemic, but not as it did in 1918, 1919. So when we take COVID or the SARS-CoV-2, it will never go away. It will be with us forever. So trying to get rid of it is not going to work. So what we need to do is when it becomes endemic, which it is already, then we have to change the situation where the pandemic ends. Now, how do we end the pandemic and the threat due to this virus is the important question. Now, if we take other viruses that did cause pandemics and or cause severe disease, but are not causing severe disease anymore, like even the mumps, measles, rubella, and all the infections covered by the childhood vaccines, the reasons that they are not causing severe disease, or because some of them, of course, completely prevent infection, like with measles, but some vaccines out there don't prevent infection. We know that influenza vaccine immunity is not lifelong. Tetanus, we need to give boosters. And if you take other vaccines, like even those given for animals or even for humans, like rabies, they do not give a lifelong immunity. So, and we have learned that, of course, the COVID vaccine is not giving lifelong immunity, which we actually lived last year. Because last year itself, when we were initially infected with the original or ancestral SARS-CoV-2 variant, after a while, we saw that people with asymptomatic infection, actually, there were no detectable antibodies, which means that they were susceptible to infection. And of course, the variants came, and these individuals who were not previously infected and some individuals who were previously infected got infected with these various alpha, beta, gamma, delta variants. So we only have 4 variants of concern. There are so many other variants, as you know, epsilon, lambda, and so on, which after going through all the data, the WHO has not named them as variants of concern. But we have 4 variants of concern, and we are stuck with Delta right now. So how do we move forward with Delta is by achieving that immunity level in the population that when people get infected, which they invariably will at some time point, unfortunately, then they will not develop a severe infection. Now, if we look at the other human coronaviruses, there are several other human coronaviruses which we get repeatedly infected. But these are usually the initial infection occurs in childhood, and then children are very miserable. They have a little bit of fever, runny nose, sore throat, and all that. They're quite miserable. And then throughout childhood, adulthood, you get repeated infection. And when you're an adult, actually, when you get the repeated infection with the same coronavirus, you've had it like 6-7 times before. And most adults actually, although their kids are infected and have a common cold, they are not. I mean, sometimes the parents have runny noses, but the grandparents are fine because you have developed immunity. So we will have to go there, unfortunately. And the best way to go there is through vaccination, not allow people develop natural infection, because natural infection, although mild in a majority, will unfortunately also kill off all the susceptible people, and we do not want that happening. This is why there are vaccines, and by taking vaccines, we can end the pandemic, but live with the virus. Thank you.
Right. Thank you, madam. Over to you, Saraji, madam.
I think I will move again to Dr. Satish Chandra again. So we have some misnomers on drugs that are used in COVID-19 infection, and also about the supportive therapy. So especially when they are home care, what are the specific drugs that you recommend when the patients are managed at home? And so like, can we sort of, I know that the call centers do inquire about their health and everything. So are there any medications that have been used in them at home?
Yeah, yes, Saraj. Yeah, I think that's a very important question to answer. Actually, patients with mild disease who are at home being monitored by the call centers, they do not need any specific treatment for COVID-19. That's something that I must emphasize. Because we have not found an antiviral drug which is effective against COVID-19. Lots of trials are going on, but there is no drug that has been proven to be effective as an antiviral, although there are lots of candidates that are being studied at the moment. So it's important for us to realize that we should not be prescribing drugs that are not in national guidelines. I mean, there is no drug that is advocated to be given outside the hospital setting for COVID-19 in any national guideline anywhere in the world. So I think it's important to realize that. Now, of course, these COVID-19 patients will have certain symptoms. I mean, they may have nasal symptoms, they may have nasal congestion, some may even have rhinorrhea, some may have an irritating sore throat. So there will be symptoms, and of course, the dry cough. So we could use drugs to give some symptomatic relief if the symptoms are a little excessive. For example, if there is severe rhinorrhea, it's quite perfectly all right to use an antihistamine drug like loratadine. So under the care of the call center doctors, the patient could be prescribed that. And of course, if they have nasal congestion, we could give something like carbamazepine, or of course we can advise them to do with steam inhalation as well. So just symptomatic treatment for those. Then for fever, if the fever is more than 100, like we could give them paracetamol. And of course, it's very important to emphasize that they should be told of the correct dose to use. They should not be overdosing on paracetamol, because that can also cause issues. Then it's important for them to take their usual medication. I think that is one thing that we have to highlight. Sometimes some patients, even though we have advised patients with comorbidities to be in hospitals, sometimes some of the patients are still looked after at home. So for those patients, it's important that they continue with their normal blood pressure medications, normal blood sugar medications. And if they're on aspirin should be continued. So those drugs should be continued, and they should not be stopped. And one other important thing is that, I mean, some of these patients do have access to a blood pressure meter or a glucometer at home. So we could ask them to monitor their blood pressure, monitor their glucose levels, and then the call center doctors or 207 doctors could advise them on how to adjust treatment. There may be some adjustments needed. Then again, of course, if there are other symptoms like vomiting, then of course antiemetic can be prescribed. And one very important thing that I must mention is that steroids should not be used in the first week of treatment when the patients are being treated at home. The important thing is, because if we do give steroids, I mean, there's no indication to give steroids, but if we do give steroids, then the patients will take a prolonged time to clear the virus. It will be prolonged, so that is going to have very bad effects. So it's very important for us to not take steroids. And the other thing is about antibiotics. Actually, they do not need antibiotics in the first week in most cases, because it's a viral infection, and antibiotics will not cause any, will not give any added benefit. Because there were trials initially about, and I think in some guidelines, azithromycin was used, doxycycline was used, but all these drugs have now been shown beyond any doubt not to be effective as antiviral, as you know, with regard to COVID-19. So they should not be used, and there is no secondary infection generally in the first week of the illness. And patients who are on asthma, I mean, they could, I mean, their inhalers should be continued. And especially, I think a patient who developed wheezing new during the COVID illness could be prescribed something like a budesonide inhaler, which is budesonide has shown some promise in treating COVID-19 patients in limited trials. So it's being investigated in larger trials. So budesonide is a good option to use. And of course, I think I should mention this. There is, I mean, in some other countries, ivermectin is used as an antiviral, but I must say that in our national guideline, ivermectin is not advocated. And the reason being that, I mean, the study is done so far on ivermectin in COVID-19 have not shown a definite benefit. And of course, there have been some conflicting reports from various countries. And the other issue with ivermectin is that nobody knows what dose to use. And in those trials, different doses were used. Ivermectin is a relatively safe drug, but there have been case reports of liver toxicity and in high doses that could cause hallucinations, dizziness, and neurological symptoms. So it's not exactly a safe drug to use. So as of now, I think it's not used in any national guideline, and WHO says clearly that it should not be used outside clinical trial setting. Of course, it's okay to use it in trials, but not in home monitored patients who could develop issues. Remember, these patients have a viremia going on, so we do not know how a drug would interact in a viremic environment. So it's important not to use that. But three things I must emphasize on, three supportive methods of treatment that we must emphasize on. Those are proper hydration, then rest, and proper nutrition. So those are three aspects that we should really stress on. Hydration. The patient should be encouraged to take at least about 2.5 liters to 3 liters of fluids per day, depending, of course, on their other conditions. And the patient should be advised to rest. I mean, that is something important because, you know, this is the time when patients are at home. So there is a tendency for some of them to get themselves involved in other activities like, you know, house cleaning or things like that. So I think it's a time when they should rest. So we should advise on proper rest and proper sleep. Those are two important things. Nutrition, again, I mean, proper nutrition, we know what basic food items should be given. So nutrition is very important. And I think there's another school of thought. I mean, some people advocate the use of vitamins, but actually, again, the three vitamins that are sort of widely sort of used in certain setups are vitamin D, vitamin C, and of course zinc. But again, no trial has clearly shown that they are of benefit in treating COVID-19 illness. Of course, there have been some reports of vitamin D levels being low in patients with severe COVID-19, but then vitamin D levels are low in patients who have diabetes, who have obesity, who have poor immune status. So, I mean, vitamin D in those instances could be just an innocent bystander. It may be the illnesses per se, the comorbidities per se, which had conferred severe disease in that group of patients. So again, there's no trial evidence to use vitamin D, vitamin C, zinc. So basically, I think in the home care management, what is important is, if I summarize, for them to have to maintain good hydration, to rest and sleep well, and take good nutritious food, and of course take their normal medicines that are prescribed for their comorbidities, and of course monitor the blood pressure and the blood sugar levels if those facilities are available. And then, of course, if they do have symptoms, under the guidance of the call center doctors, they could be given treatment like antihistamines, paracetamol, basic symptomatic treatment. So when they reach, in case of patients who drop their saturation, if the saturation drops below 96, then we do know that they have to be taken into hospitals. And when the saturation level drops to 94 or below, that is the critical point at which we start specific anti-COVID treatment with oxygenation, then dexamethasone, and anticoagulation. So I think that's another topic. So I will not elaborate on that. So until then, so patients should not take steroids, should not take antibiotics unnecessarily, and stick to basic evidence-based treatment. Because after all, I mean, as was said earlier, 80% of the patients do not require hospital admission. They improve well. And if I give an example, I think there was a time when the ministry had followed up some patients in home care, and one figure they cited was that within a period of 2 to 3 weeks, they had about 35,000 patients in home care. Only 500 patients had to be admitted, and all the other patients were at home, and there had been no deaths at home. And those patients at home had not received any specific drug. So if we had given drugs unnecessary to them, that would have been a colossal waste. So it's very important to know that we stick to evidence-based medicine in treating these patients.
Okay, thank you very much, Dr. Satish. My last question on home care. When do you end a patient on isolation? What is the end? That means the period that they should be in isolation.
So generally, I mean, if it is mild disease, I mean, which is what we see in most patients, we say that by about day 7, replication competent virus is not recovered from these patients. So by day 7, they become non-infectious generally. But of course, you may be knowing, in hospital settings, we do keep the patients for an additional 3 days and discharge them on day 10. Certainly by day 10, they will be non-infectious. Now, as for protocol, we advise patients to be, patients to isolate themselves until day 14 at home. But generally, I mean, after day 7, they become non-infectious. Of course, patients who go on to develop severe disease can continue to excrete the virus. So they will not be non-infectious. So that's a different category of patient. But patients who are at home, who recover well, who feel well, who are free of fever, who are free of major COVID symptoms, which is the case in most patients by about day 7. So from that point onwards, they are not infectious. As per ministry regulations, there's a margin that has been given. So the patients are isolated at home 14 days, and certainly after 14 days, they do not need to check antigen or PCR. They can resume their normal life. They can go on to be active members of the community. But one thing that I would like to say, somebody may have a few symptoms that can linger on, like a slight cough, a little bit of phlegm. That is no cause for concern. Doesn't need any treatment also, so should not, such patients should not panic and then get back to, seek treatment from doctors. That's usual, and those symptoms will go down. Of course, if they do develop more severe cough, more severe symptom, then they should seek medical attention. And one other general thing we advise the patients on is to maintain good hydration still, even after the period, and to rest. And they should not exert unnecessarily. I think lots of patients do want to get back to their active lifestyles very quickly. Sometimes when they do that, they may have a bit of fatigue going on. So we generally advise them to rest for a while. And it's quite a different matter in patients who develop severe COVID-19. Of course, then when they are discharged from hospitals, a certain well sort of streamlined advice is given. But for patients who were in home care, generally they are quite okay to resume their lifestyles, but with general sensible measures, not to overexert. Thank you.
Okay, thank you very much, Dr. Satish Chandra. Right, Sajid, do you want to take?
Yeah, thank you, madam. Before moving on to the next speaker, if you all have any questions, please put your questions on the chat box. I see a lot of questions are coming in, so we will give time for you all to answer questions and get answers from the panelists. So my next question moves to Dr. Chandra De Silva. So, sir, now we see the childhood vaccination program has started for the children with special needs from 12 to 19. So could you elaborate on the current situation on this childhood vaccination program? And if a child who has just passed 19 years with a disability, for an example, Downs or Duchenne muscular dystrophy, so can they also receive the vaccine from this program?
Yeah. Yes, so this vaccination of children against COVID-19, we are planning to roll out in 3 phases. The first phase is vaccination of children with underlying comorbidities, especially medical conditions or chronic diseases. The theory is if these children develop COVID-19, the chance or risk of developing the severe disease or especially mortality is little high. So according to the data in other countries also, and with our limited experience in Sri Lanka also, few the children who have died, some of these children had this type of underlying comorbidity. So that's the reason. So with this process has started with children with some sort of underlying comorbidity. So that should be some sort of severe diseases, like for example, at the first phase, we don't consider children with mild asthma, even though they have so like that. So the main important thing is risk versus benefits, because we are giving this Pfizer vaccine. There are rare cases of myocarditis associated with Pfizer vaccine, but that's also mostly following the second dose and children 12 to 15 age group. And there are various reports about the prevalence of this side effect, but usually it says about 2 to 3 cases per million, and no deaths have been reported. So because of that initial phase, it's mainly for children with comorbidities. Very clearly, the risk of getting this type of significant adverse effects are clearly outweigh the benefits of receiving the Pfizer vaccine. The next phase, it's planning to give children, all the children over 15 years of age, which cover the A-level and O-level group as well, but that has not been approved by the ACCD yet. And then that is also in the discussions. And the third phase, the last phase, would be all the children between 12 to 15 years of age. Even UK also, that has been approved very recently, 12th of September. So that is the phases. As going to your questions, the currently it's 12 to 19 years of age that is given, vaccines are going on. But obviously children about 20 years, not children, sorry, the adults about 20 years, 20 to 30 years of age, already this process has been commenced. The some places, some district, Pfizer vaccine has been given, but now most of the places, rest of the country, Sinopharm vaccine is given. So that is already going on, that process. Even the person have a chronic disease or not, even though completely healthy, all are eligible to receive that vaccine. But their issue is most of the time they are little reluctant to receive this Sinopharm vaccine, and they also wanted to get the Pfizer vaccine due to some other reasons, not mainly the medical reasons. But 19 to 20 is a little gray area, but still they can obtain the vaccines. But over 12 years, obviously, we cannot provide under this scheme, because we are having that practical issue as well. Even the first day, when we start this vaccine rollout process at LRH, we got few patients with some sort of minor issues, but they are over 20 years. They came to obtain the Pfizer vaccine. Currently, any child with some sort of significant comorbidities can obtain vaccines. From tomorrow onwards, it will be given in almost all hospitals, base hospitals and above, throughout the country. One thing is, this is usually done by under supervision of a pediatrician or physician. That is to make sure that first thing is to identify whether there is any clear evidence of a chronic disease or clear indications. Next thing is to observe them, because these children now, the adolescents, are having some other issues. Just to observe them, as well as most of the hospital, even LRH, we provide the hotline number to contact. And that is just to troubleshoot. If they develop some sort of a mild issues, then we can address them. For example, actually, I answered the phone, LRH phone, from first day to day 3, last Friday, Saturday, Sunday. The most of them, the concern was they developed mild headache, mild fever, body aches, and some few develop vomiting and some sort of a mild symptoms. But most of them recovered with paracetamol. At the moment, we didn't have any reported cases of severe adverse reaction following these immunizations. At the moment, that is going on smoothly.
Right. Thank you, sir. There is another question for you. When and how can we reopen our schools for our children?
Is to give education. So it's an overall thing, especially it's important for the child development. So it's overall thing, yes, as much as possible, as soon as possible, you have to open school. So all these depend on the disease spread among the, especially the rate of positivity. That's some sort of a indicator about the disease spread among the patients or within the country. That is also planned in few phases. First phase, it will be very soon. Now the southern province has informed they will start the second weeks of next month. Especially children, the students less than 200, schools with children less than 200. That is most of the time the primary schools. Anyway, the primary schools less than 12 years, we don't give vaccines. So then vaccination is definitely not the issue. And these schools are small schools most of the time. The draining area is also local people, the children with local people attend to these schools. And most of the time they don't use public transport systems, and they have ample spaces in these schools. So it won't produce significant issue to the disease spread. And recently also the UNICEF also has released a document regarding this, especially regarding the school opening. They also very clearly mention the disease spread. So one of the main concerns regarding the school opening is whether it might create some sort of school clusters, whether it's accelerate the disease spread. So as we currently understand, the disease spread in comparison to adult to adult. The comparison to adult, the disease spread between children to children, child to child is significantly less, as well as child to adult is significantly less. So because of that, yes, although there's a possibility, but children acting as super spreader or the creating this school clusters very unlikely. So because of that, when the disease spread getting, now we know that the number of cases has reduced less than 1,000. Recently, Indian Pediatric Association, they have released a document. So their estimate is, if the positivity rate of these PCR, so COVID test, if it is less than 5%, they can start schools. That is according to local things. Like that, we may have to develop our own thing, but roughly it's when the disease spread is reducing, step by step we can go. But obviously the schools with children over 2,000, 3,000, the thousands, most probably it will take little time, and that's also as done in earlier. Have to divide the classes into few groups and get down them in different days, because that's the usual way. Increase this social mobilization, especially schooling is significantly associated with increased social mobilization, especially for national schools. So it will take little time.
Thank you, sir. Again, over to you, Saraj Madam.
Okay, thank you, Sajid. So I'll move on to Madhura again. Madhura, when these pregnant mothers get positive for COVID-19, we have seen that they rush for hospital admission because of the obvious fear that we have discussed. So when do you suggest to admit them to hospital? That's the first question. And the second question is, if anyone in the at their home front get positive for COVID-19, do they need admission, or can they be managed at home?
Sorry, Saraj, I didn't get the second question.
Yeah, so if another member in the family getting positive in the same household, again, this pregnant woman is at risk. So whether they need admission to hospital, or can they be managed like in isolation?
Okay. Yeah. To answer your first question, when to get admitted to hospital now. Initially, when we started our COVID ward, we started getting a lot of patients, and any pregnant mother who is positive tend to come to hospital. And we actually catered almost all women who came from area, like we are the kind of visit in and around Kalaboil hospital. So then we realized that we can't deal with all the women. So we, with the recommendation of the health ministry, we sorted few criteria. So we know that certain risk factors are there to get a severe disease like high BMI, general comorbidities, and the third trimester, that is after 24 weeks of gestation. So we consider that fact when we request them to come to hospital. And the other thing is the symptoms. So total asymptomatic women who are in the first and second trimester, we don't now encourage them to come to hospital. And especially as Dr. Satish mentioned, like worsening symptoms, even if they are whatever the trimester they're in, like shortness of breath is going to get worsening, and then they feel that there is chest tightening, any obstetric issue like dribbling or pain or anything like that, we encourage them to come irrespective of their trimester or risk factors. And if someone is in the third trimester, even with mild symptoms, we ask them to come. So what we do is when they come, we have our dedicated team in the hospital. So we go and then we assess them and see whether they needs to be in the hospital. If at all, we keep them for a while, like 6 days, and then see whether we can send them into our intermediate care center. And then they go home. So it's very important for those patients who are managing at home to know the danger signs. So usually worsening symptoms, if they are generally unwell, or whether there is difficulty in breathing, or if they can't complete a sentence, we ask them, if you feel like you're breathless when you go to the washroom and come, they need to ring us, and then they we can arrange them to come to the hospital so that we can assess them. And of course, as we all know, if they have a home pulse oximeter, they can check the saturation. And if it is less than 95, we ask them to come in to the hospital. So those are the rough guidance. And there are significant danger signs, like if they feel that they are short of breath at rest, or if they feel that they are getting cyanosed, they need to rush to the hospital. So they call an ambulance without even, we have difficulties in contacting people, the MOHs or the hospital may not be picking up the phone, so they should not wait, and they can directly come to the hospital and they mention they are positive COVID patient. Then we have separate place so that we can send to our COVID maternity ward. So that's how we actually managing the patient at Colombo South currently. And we have managed, I think over the last 1.5 years, we managed 250 COVID patients and delivered about 75 during this last week that we encountered. Unfortunately, as we all know, when they come late for the presentation, even the two maternal deaths that we encounter were transfer in patients who are in critical phase. So then there is nothing much that we can do for them. So if they come early, identifying the danger signs, then we can improve their outcome. And the second question, Saraji, now, if someone is positive at home, if she is not having symptoms, then she does not need to come to a hospital. They can go through the normal pathway of self-isolation, quarantine for 14 days from the first contact. And if they are asymptomatic, I don't think they need to even do a PCR according to the new recommended guidelines. However, if they are symptomatic and if they are pregnant, they need to inform the MOH, and usually MOH will call the hospital and seek medical advice. Again, we assess the risk and then we see whether she needs to come into the hospital. If she needs to come in, we can ask them to come in, and then we do a PCR test in the hospital or rapid antigen, and then we take it from there. I think that answered the question.
Yes, Madhura, thank you very much. I think Sajid, you can take over from there.
Yeah, the last speaker would be our Professor Nilika Malavige. So, Madam, now there are a lot of misnomers are going on the social media, especially about these vaccines and the immunity and the side effects. So, what is your view on these different ideas?
I think by now, all the different kinds of vaccines that have been given in Sri Lanka are given to millions and millions. And we are not talking about 2 or 3 million. We are talking about billions of people, because now 4.5 billion vaccine doses have been given of the main vaccines we are using here. So we pretty much know that they are safe. There is no question about that. Different vaccines have their side effects. We know that the AstraZeneca, especially in the younger population, it causes vaccine-induced thrombosis and thrombocytopenia syndrome. In young children, we know that this rare side effect of myocarditis is seen with Pfizer and Moderna vaccines. So those are rare side effects. Apart from those ones, actually none of these vaccines were associated with any of these side effects described in social media, which is causing abortions, causing infertility, causing impotence. And that is one of the issues that have been circulated in social media. But more than that, I think the 20 to 30 age group are not taking the vaccine rather than because of the myths. I mean, some people, yes, because of the myths, but more than that, it's because they are waiting for a Pfizer or Moderna, and they believe that they should be given a Pfizer or Moderna vaccine. And I believe that that is the main reason that that particular age group is not taking the vaccine. But as far as the myths are concerned, there is a lot of, so many people have been given billions of doses right now.
Right. Thank you, Madam. The last question. There are weakening of the immunity in all vaccines. Does that mean that everybody need to take this vaccine yearly or specific group?
Yeah, so I mean, if you look at other vaccines, now something like hepatitis B, of course, after vaccination, the immunity levels fall. And some instances in healthcare workers, of course, you do give booster doses or revaccinate some individuals. And if you look at other vaccines, like for influenza, I mean, in countries like Sri Lanka, yearly immunization with influenza is not a common practice because we are a hot and sunny country throughout the year. So we don't have a very significant proportion of seasonal respiratory infections that occur in the winter in cold climates. So in cold climates, we know that vaccines such as influenza, which change a lot, the virus changes every year. These vaccines are given to susceptible people, which are people over 60 or 65, depending on the country, people with comorbidities like diabetes, COPD, and so on. And even younger people with certain comorbidities, respiratory diseases, they are given the flu shot, we call it the flu shot, just before the winter. And this has been there for, the practice for a long, long time. So even with the COVID vaccines, immunity will wane as, I mean, if you measure the immunity with time, yes, you see that it wanes for most vaccines. So, but that doesn't mean everybody needs a vaccine. And it's not just antibodies, there are other measures such as memory B cells, which are there in your blood. And as when you re-encounter the virus, they make antibodies. So you can't just go by antibodies, but basically old individuals might need booster doses. And we know that Sri Lanka has planned giving booster doses for over 60 individuals and those with comorbidities. And I believe frontline workers as well. And that's what the ACCT recommended, which is currently done in most other countries because right now we are trying to get rid of the pandemic. We have to get out of the pandemic to move forward, and every effort is needed for us to end the pandemic, so that we don't need to do what we are doing today. I mean, which we are not doing for the other infectious diseases that cause a pandemic. So the idea is to get out of the pandemic, and after that, susceptible people may need yearly vaccination.
Right. Thank you, madam. That brings us to the end of the panel discussion. Now let's move on to the question and discussion. Saraji, madam.
Yes, I think this question should go to Neelika. So if an individual is infected with COVID-19 and after they recover, is there any chance of them being reinfected or super infected with several strains? That's the question that has been posed.
Yes, so there are documented evidence that especially people who had asymptomatic infection, the antibody levels do wane with time, and the immunity possibly as well, and they have got reinfected. We see the data from Sri Lanka, a few documented individuals, but when you look at countries like Brazil, where last spring, 2020 spring, May, June, they saw a large outbreak, and at the end of the outbreak, end of spring, about 75% of that Brazilian city had antibodies. But after that, then the Gamma variant came to Brazil, and so 75%, despite 75% being infected and had antibodies, we saw a large infection happening in Brazil, and we know what happened to Brazil after that. So many people were dying every day. So yes, in the natural immunity, I mean, immunity following natural infection does not seem to last in the majority of individuals. And so vaccine-induced immunity has been compared with natural immunity, and most vaccines, I mean, this has not been studied for all vaccines, but most vaccines do induce better immunity than natural infection in the majority of individuals. Despite the vaccine-induced immunity also waning, it is still better than natural immunity in most individuals. But individuals who got infected and then got vaccinated, or the other way around, they actually have very good immunity, and such sort of immunity is predicted, I mean, we have to wait and see, of course, to last for a long time. And after vaccination and all these things, how susceptible are you to the emerging variants? I mean, because right now we know we have Delta, and Delta accounts for 99% of the infections all over the world. I mean, we had these other variants called, Alpha, Beta, and Gamma, but they only account for around 1% of the infections all over the world. In most areas of the world, there is only Delta and no other variant. And those other variants like Lambda and Epsilon that people were interested in and concerned about, when Delta went to those countries, they were wiped out. And everybody was scared about the Beta variant because it escapes immunity. But when the Delta went to South Africa, it wiped out Beta, and Beta is no longer there in South Africa. So Delta will be here to stay for a while, and well, Delta might be replaced by another variant. But the question is this: I don't know if you listen to Professor Sarah Gilbert's talk. A virus will mutate, but there's a particular level a virus can mutate without it being at a disadvantage. So when it mutates too much, then it can't cause infection. Also, the ability to cause infection also falls. So I think, yes, there will be mutations that or variants that may replace Delta in a few months. We don't know when, but vaccines are likely to hold, and the vaccine-induced immunity is superior to infection-induced immunity in most individuals.
Thank you, Nilika. I think that's another question. Actually, I think more Dr. Satish also could help answering this. This says, now in older patients, when we give vaccination, some of them develop severe adverse effects like severe debility, loss of appetite, and they are really unwell. So what do we do with this group? Like just general disability, poor appetite, and things like that, especially in the older group.
I think it's in the elderly group, the vaccine is very much indicated. I mean, it's in that particular group that disease severity is more, and the chance of hospitalization, need for ICU admissions, and even death is more. So that's the group that we have to concentrate on giving the vaccine. So you could have some side effects in the initial couple of days, 2 to 3 days, but I think in most instances they can be managed quite well. And I think if you think of a percentage, I think it's in a minority of elderly people who get these adverse effects initially, actually. But in those who do get, I mean, we could maintain good hydration by giving them fluids, and then of course if they have fever, can give paracetamol. So symptomatic management is enough for most of them, unless of course they do develop severe symptoms, in which case we have to assess them in hospital. But in the vast majority of elderly people, they do not react that much to these vaccines. I think Nilika might be able to enlighten us on that a bit more.
I think I have much to add to that. As Sati said, most elderly people don't have a lot of side effects except for the extreme elderly, where symptoms like diarrhea might cause an issue when they're very debilitated. But actually the side effects or the reactogenicity of the vaccine was less in older people compared to younger people for most vaccines.
Okay,
Right.
thank you.
Thank you, madam.
Yes.
There is another question. I think it goes to Nilika, madam. Is there any benefit giving vitamins as immune boosters?
Yeah, I think Dr. Sasi's answered that question. Now, when we, I think it is important to understand what we mean by immune boosters. So it is like talking about your blood pressure. You have a normal blood pressure and a normal blood glucose level. You don't want to boost your blood pressure. Okay, so you have to like the pH of the body, the blood pressure, the blood glucose, all of them are at optimum level. And when they're at optimum level, they work the best. So, and these vitamins or other so-called immune boosters, there is no such thing scientifically called immune boosting. I mean, the scientific term called immune boosting does not exist because all our body systems work in that optimum range. So I don't know about this immune boosting, but for the immune system to work in the optimum manner, of course, if you are vitamin B deficient, then that has particular problems with the immune system working in the optimum manner. If you have certain comorbidities like diabetes and so on, then you have problems with your immune system working in the optimum manner. So certain comorbidities affect the performance of your immune system, so that is a different story. But giving vitamins to boost your immunity, that is a myth. Thank you.
Right, thank you, madam. So there is another question for the panel. When can we start the exercises and going to the gym?
Dr. Satish, will you like to answer that?
Yes. Yeah, I think I briefly sort of referred to that as well. So generally, I mean, once they recover, let's say after 14 days, and we advise them to get back to work and to go on with their normal activities. But I suppose we could get them to, rest a little bit and not immediately engage in heavy exercise, go to the gym and all that. So it's very difficult to sort of generalize and say that it's okay after this this period of time. But perhaps in younger individuals who did not have, who had just mild disease, they should be able to get back to their normal activities, even exercise after a couple of weeks. Of course, we do encourage them to walk, and we do encourage them to be mobile. So that's one thing. But I think when it comes to very sort of strict exercise regimes, I think that maybe we could sort of defer them by a couple of weeks or more. And I suppose in more elderly patients, I think they should be more careful about engaging in severe exercise, because some of them do complain of some fatigue-like symptoms. So those could be made worse. And even on people who are restarting exercise, it must be stressed that if they do feel short of breath, if they pant, then it would be a good idea to reduce the level of exercise, maybe engage in only mild exercise for a while. This is true of most viral infections, I suppose. I mean, even following dengue, people would feel a little run down. So that's something that's common sense that we should employ in deciding when to resume more severe exercise.
There's one question on whether we could use aspirin and atorvastatin for the highly selected patients in order to prevent thrombosis, and if that can be given, yes, or if not, why?
Yes. Well, yes, certainly. Even in the national guideline, it is advised for people who have a high cardiovascular risk. If people have a high 10-year cardiovascular risk of, let's say, about 15% or more, that is in other words, patients who have ischemic heart disease, hypertension, diabetes, chronic kidney disease, and other cardiovascular ailments. I mean, they should be on aspirin. So patients who have been on aspirin, they should be continued on aspirin. Patients who need to be on aspirin and who are not on aspirin, either due to omission or non-compliance of patients, then we can certainly we can start aspirin new in these patients who have a high cardiovascular risk. Same applies to statins. I mean, if a patient had been on statins, we can continue. And patients who have not been commenced on statins, even though it is indicated in them, we could start statins during their treatment period. As to whether we should start aspirin or atorvastatin or another statin new in patients with COVID-19, I think that's a bit of a controversial thing. Now, there has been a big study in the UK. There is this recovery group which has done a lot of work on various treatments, and they reported on their aspirin study. It was a randomized control study, and the outcome was that there was no benefit of giving aspirin to patients who are hospitalized. That is, giving aspirin new to patients who are hospitalized with COVID-19. So probably, I mean, there are some other studies that are going on, but there is no definite proof that aspirin should be prescribed to patients new for COVID-19 in the hope that it would prevent thrombosis. Now, patients who are discharged from hospitals following thrombosis, or rather following COVID-19, need an independent assessment to see whether they have an increased thrombotic risk. We do not use anticoagulation routinely in those patients. Of course, if the patient had a pulmonary embolism or DVT, then the usual protocol will apply. But if a patient has not had any thrombotic event, then it's an individual assessment to see whether we do need to continue anticoagulation or not. So we consider we balance the risk of risk of bleeding and thrombosis in that instance, and then come to a decision based on that particular individual patient. So in general, we don't start aspirin or statin new for these patients, but if they are already on, or if they were not on, and if they are indicated to be on those, then of course we do start aspirin and statins.
Thank you very much. I think one last question in the interest of time. There are many other questions. I think this goes to Nilika as well. Now, patients with malignancies, especially the hemopoietic malignancies, when they are treated in the hospital with COVID positivity, the rat seems to be positive for over a month sometimes in some patients. So whether is it necessary for them to sort of, what is the plan of management for them, and also whether any further immunization is necessary to boost their immunity? That's the question.
To talk about these patients with hematological malignancies, they're obviously suppressed, including other people with chemotherapy, kidney transplant patients, and so on. And but Dr. Satish very clearly said that getting rid of infective virus within 7 to 8 days does not happen in immunosuppressed patients. So they can go on shedding infective virus particles and the virus actively replicating in them for a month or even more. So this is why this rat is continuously positive in patients with malignancies in these hospitals. And so this is the issue. Of course, how they should be managed, of course, you have to manage them as infectious because I've seen sometimes after 14 days in certain hospitals, not in Colombo, that after 14 days, even if the patients have severe disease or malignancies, they are considered non-infectious, which is not true because immunosuppressed patients can be infectious for a very long time. That is, so you have to manage them as infectious. And about vaccination, again, we get a lot of blood samples sent to check antibodies to our department. And what we have noticed is even after being fully vaccinated, patients who have had kidney transplants, who have malignancies, that category of patients have not seroconverted. In other words, have no antibodies. And after a third dose was given, so it is not considered as a booster dose. When a third dose is given to such immunosuppressed patients, they did respond to the vaccine. And this is being practiced in other countries also. For immunosuppressed patients, a third dose of vaccine is given. And I think in Sri Lanka now, since anyway, people with comorbidities have been decided to be given a booster dose, this would be really helpful. Thank you.
Thank you, Nilika. I think, Sajid, in the interest of time, we have to wind up this very interesting session. Sajid,
so now it is almost 2 o'clock. So we had a very valuable discussion for nearly 1.5 hours. So on behalf of Staff Development Committee, I would like to thank all the panelists who participated with us. Dr. Harsha Satisandra, Dr. Channa De Silva, Professor Nilika Malavige, and Dr. Madhura Jayawardhan for the excellent presentations and the views and clarifying doubts and joining with us despite of their busy time schedule. So this video record will be available on Faculty of Medical Sciences YouTube channel in a few days' time. And thank you very much once again for all the panelists and all the participants for joining and clarifying your doubts. Thank you very much.